Well, thanks very much. I'm really happy to be here and tell you about this work. So as you can tell from the fairly long title, I'm going to be talking about the effects of childhood insurance coverage, but focusing on effects on outcomes measured later in life. And so just to get into the topic and kind of let you know what the context is and what the outcomes are, I'm going to start by showing you these two series that describe how public health insurance works for kids in the United States. The two green lines are different measures of the share of children, 0 to 18, who are publicly insured. And the blue dots are the share of kids who are uninsured. And in this picture, I've cut these two series off to represent just the years where we have gotten most of our evidence on how Medicaid affects kids. So starting in 1996 with two papers by Janet Curry and John Gruber, economists and other health services researchers have really made extensive use of eligibility expansions throughout the 80s and 90s that granted new Medicaid eligibility to different groups of children or pregnant mothers. And they've summarized a lot of those policy changes and looked at their effects many, many times. There's probably hundreds of papers maybe at this point on these 80s expansions. And they generally find that in the short run, kids and infants and mothers who get Medicaid experience a number of benefits in terms of health, in terms of utilization, it increases coverage, and in many cases it leads to interesting behavioral responses on the part of families, things like dropping private insurance coverage in some cases or changing labor supply. But that's really basically what we know about how Medicaid works, and those are the research studies that get cited almost all the time when folks talk about what Medicaid does for kids. And that literature at this point is 20 years old, and it's very well trodden territory. But just in the last few years, there's been a new crop of papers that have gone back to re-examine the same policy changes that took place in the 80s, but to look at their impacts not on the short-run effects on kids right here, but on effects on those same kids when they are in early adulthood over here. And that stuff's all come out in the last couple of years and has generated evidence that fits really nicely with the short-run impacts on health and utilization, because they find that groups of kids covered in the 80s grow up to be healthier by a number of measures, to work more, to be more educated, and to use less medical care for things like chronic conditions. And some of that stuff's been done by people here. Bruce Meyer is a co-author on some of those papers. And so that's much newer than this 20-year-old literature starting in 1996. And that's really what I'm going to contribute to today. And I think that I'm going to tell you what I'll do, and I want to point out what I think are two important limitations for what we can learn from the 80s that hopefully I'll overcome today. So the first one is just a limitation about that's related to time. Kids at this time just aren't that old now. So for example, some of the variation that people use is based on a rule that granted new Medicaid eligibility to kids born after September 30th, 1983. It's a really interesting birth date discontinuity. It's a really cool research design. But I, for example, am on the control side of that discontinuity. And I'm not that old. I probably have lots of health problems that are still in front of me, and so I haven't experienced them yet. So it doesn't mean it's not interesting. It just means that we might not know about a fuller sense of Medicaid's long-run effects by looking at cohorts when they're like in their 20s, maybe early 30s at the oldest. And another limitation of the 80s is that a lot of the ways that the Medicaid expansions of the 80s worked was to give new Medicaid eligibility to people, but also at the same time, in some cases, give them related programs. So many new Medicaid eligible families in the 80s also got access to the WIC program. Some of the expansions, especially in the early 80s to pregnant mothers, were about liberalizing the rules in cash welfare, which then granted Medicaid eligibility. So some of these groups, which have been shown to benefit in many ways, actually were treated not just with one thing in the 80s, but with potentially two or more different kinds of policy treatments. And so both of those things they don't really get in the way of interpreting this literature as the effect of the 80s expansions, but it makes it a little harder to know what was really doing the job. And so today I'm going to revisit, I think, those two limitations by looking at a different period of expansion in the public insurance system, and that's when Medicaid was first put into place in the 60s. And as you can see, this is also a period of very rapid expansion in the share of kids who were publicly insured, and as I'll point out again later, it corresponds to a similarly large reduction in the share of kids who were uninsured. And so this is another distinct and very meaningful period of time for growth in the public insurance system. You can see just by definition of this x-axis that these kids are going to be much older over here than the 80s kids. And I'll describe some of the ways that this policy worked and argue that it doesn't really run into some of these other bundled treatment issues that I think might be at work in the 80s. So essentially what I'm going to do today is just show you a lot of historical information on how Medicaid worked when it first started over here and argue for a particular identification strategy that generates good comparison groups in the 60s, and link that stuff up to outcome data that I observed, not all, but basically from 2000 to 2014 or so. And everything that I do here, I'll say this a couple times to make sure people know where I'm going, but everything here is going to be all collapsed down to the level of the cohort. So I'll be comparing groups of people, outcomes for people here who were born in different states and in different years, back here surrounding this time. And what I'll basically show you is that kids who were exposed to more Medicaid, in a sense that I'll make precise later, more Medicaid here grow up to have lower mortality rates in the 80s and 90s, to be less disabled report being less disabled in the 2000s, to work more and to use public programs, particularly those related to disability, much less up here. And one of the important upshots is going to be that actually the spending that we did 50 years ago translates now into quite a bit of public savings over here, generated from lower use of public benefits and increased employment. And then these health benefits that I mentioned are also very valuable to individuals on their own. And so basically the upshot of the paper is going to be Medicaid's effects really do persist over a long period of time, and they're meaningful both to the individual and to the government. Oh, I should also mention, I'm happy to take any questions at any point, like clarifying questions, argumentative questions, before, during, after, it's all fine with me. But I'm going to start now by telling you a bit more about Medicaid implementation and when it happened and what features of Medicaid implementation, in my opinion, made it such a large policy change and so meaningful in this way. So by way of context, this is a figure that I generated from 3 different survey data sources from the early 60s before Medicaid existed that show the income profile for children of the probability that they had seen a doctor in the last year. And so this shape is nothing like this shape exists now. This is a very, very stark income gradient in this very basic measure of access to medical care. So this says that the poorest kids in the early 60s saw a doctor less than half the time. And if you were to make this same plot today, it would be more or less a straight line shifted up to about 85, 90, 95%. I mean, that's not to say that there are no disparities in medical care today. It's just this crude measure of did you see a doctor no longer has this kind of stark gradient. And so the reason, I mean, the reasons for this are, I think there are 3 reasons why poor kids weren't seeing doctors at this time. One, their families were poor and they weren't paying a ton out of pocket. 2, if you talk to the American Medical Association in 1963, they would have said, well, this can't be true because our members are happy to provide care for all of the indigent members of our community. And that seems not to be true, both from direct reports of kids and also from other survey reports of the time where families are asked, did you get free care? And they just don't say that they got it very much. They don't report having lots of access to free care, and this suggests they didn't have it. And actually, even some historical reports suggest that when families got some kind of free medical care, its quality could be very dubious. And there were many other access barriers to actually getting that free care. And then finally, there were not other sources of insurance. So the private insurance system was still growing in the early 60s. It really took off after World War II, and it was still expanding. And was certainly less common among low-income families who were the least likely to have some kind of new employer-sponsored plan. And the public insurance type programs that predated Medicaid were pretty small at this time. I'll talk more about those in a second, but there actually were pre-Medicaid public kind of insurance programs. It's just that their financing, the federal financing for those programs on a state level was very limited. And so states did not establish generous programs, and they did not cover very many kids. And so this set of factors, inability to pay out of pocket, lack of free care, lack of other kind of insurance options, obviously leads you to this kind of conclusion that the poorest kids simply didn't get a lot of medical care at this time. A little bit. You get a similar thing by race, if I remember, but some of these surveys don't have other geographic codes I can use this time. So for this illustrative one, it's all just aggregate, but that's a good question. Yeah. I think that's true. I haven't made it by race for a while, but I think that's the pattern that comes out, yeah. So that context, very low utilization among the poorest kids, is the context into which Medicaid was passed in 1965. And Medicaid was included in the 1965 Social Security Act amendments. And this picture shows Lyndon Johnson signing that act. And actually, this picture from the Social Security Administration is called President Johnson signs Medicare into law, because Medicare was by far the focus of this legislation. Medicaid was actually structured and included in that legislation as a political compromise to protect Medicare's universal coverage and its mandatory Part A coverage of the elderly. And so really nobody was paying attention to Medicaid in 1965. It wasn't even described as insurance for a couple years, and it was viewed just as a small expansion of existing programs. It really went under the radar. But I think it turned into a big program for three important reasons. So the first is that it instituted open-ended federal financing. And what I mean by that is the programs that predated Medicaid that I mentioned a second ago were limited exactly in the way that the recent health care bill proposed to change Medicaid's financing, which is that the federal government would pay some amount of state costs for the medical care of welfare recipients, but they would only pay up to a fixed amount. And so that cap on federal financing meant that those pre-existing state programs were very small. States were really reluctant to establish generous eligibility criteria because if a lot of people signed up or a lot of people needed care, they were going to be on the hook for all costs over this cap. And so Medicaid ended that and instituted what we have now, which is this open-ended federal state financing system where whatever Medicaid's costs are, the federal and the state government share it according to estimate. So there's a lot of money at stake. That was one huge feature of Medicaid that made it large. Two, it kind of imposed this essential health benefits basically, and all Medicaid programs had to cover inpatient, outpatient, physician, lab x-ray, and then also nursing home services. Because I'm talking about kids, I'm not going to focus on nursing homes, but actually that's really important for how much Medicaid costs, but we're going to totally sidestep nursing homes for today. And states could also choose to get federal reimbursement for stuff like drugs, which most of them did, and other things like clinic services, which allowed states to reimburse community health centers through their Medicaid program, things like that. And then, because later on I'll tell you more about disability, I also want to emphasize that starting pretty early in the program's history, states were also kind of generating or building up these early periodic screening, detection, and treatment programs where they went out actively and sought out kids who were suffering from potentially disabling conditions and provided screenings, and they were tasked with essentially actively connecting those kids to some kind of care. And so all these things were part of what one got when you signed up for Medicaid. And so the services were meaningful. The final thing that I think made it a big program, and that's going to be the basis of my empirical strategy, is that it mandated coverage of all welfare recipients. So previously, states were able to cover some groups and not other groups. So like Michigan, for example, didn't cover hospital visits for children. I think California didn't cover children at all. But Medicaid said, no, everybody who is receiving a cash transfer program has to be eligible for Medicaid. And this really mattered for kids through basically one program. Again, for other groups, this is called categorical eligibility. This mattered through programs for the elderly and the disabled and the blind. But for kids, it almost acted entirely through aid to families with dependent children, which, as I'm sure you know, is like, of course, the cash transfer program for single-parent families. So what I'm going to do later is to utilize this feature to pick out differences across states and where this new policy would have hit harder. So some states just had higher shares of kids on AFDC than others, and this legislative language means that statutorily they got a bigger kind of dose of Medicaid than other states did. And so this is a really important provision, both for Medicaid historically and for me empirically in this paper. So this is what happens to this simple share of doctor visits just 5 years after Medicaid was put in place. This is an unprecedented change in the medical care use of poor kids. So this line is similar now, again, but just shifted up. But there's been no other time since the 60s when there's been any change this profound at all in the utilization for poor kids. And so, you know, something on my to-do list is to generate more precise evidence on Medicaid's role in this change, but it's incredibly striking that soon after a program targeted at medical care use among the poorest kids was put in place, in fact, medical care use among the poorest kids increased by just a historically large amount. Okay, so why, I mean, that, oh yeah. Mm-hmm. Yeah, I think. Yeah. No, that. Mm-hmm. It could have been. Yeah, that's for sure. So yeah, I don't think it's obvious from this graph that the Medicaid treatment effect is, 40% percentage point increase in utilization. In terms of my design, I can use some of the data we have on health center funding and ask whether it's correlated with my measure of AFDC-based Medicaid eligibility, and it really could have been. It turns out empirically it's not, so that's helpful to me. But it is true that Medicaid could have been moving poor kids from those like charity community providers or community health centers to other providers, and maybe freeing up space for other uninsured kids to go to a health center. There might have been spillovers within a community like that where Medicaid, if everybody's crowding in one hospital, Medicaid shifts some people somewhere else, might free up space in that hospital. So there is an interesting question about which children in a community were affected by Medicaid. It need not be just the Medicaid eligible kids. So it's hard. There are data limitations about getting at that. Yeah, that could be true. Okay, that's a good point. Yeah. 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 Yeah, that's true. That's true. Yeah, I mean, I think. No, that makes sense. I think that's a sensible story, and I think luckily for me, it doesn't seem the health center capacity was appreciably larger in states with higher AFDC participation, or higher child Medicaid eligibility. So it could have been, but I think empirically it turns out not to be true. So that's lucky for me. Yeah. Mm-hmm. Yeah. 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 Mm-hmm. Yeah, that's possible too. Yeah, one concern would have been, so later I'll basically show you differences models where I look at cohort outcomes, like for cohorts that are born before Medicaid and after Medicaid in higher versus lower AFDC states. And you could have imagined that a problem would have been if AFDC growth meant that the high AFDC kids just got even more AFDC over time, and they were spreading out, and they really were getting this sort of packaged treatment over time. And again, that's a very plausible story. I was worried about it too. Empirically, it actually seems like AFDC was going up in a lot of places, and for the most part, not doing so differentially in states that were already high versus already low. It was kind of just going up largely together. Yeah. Similar. I'm sure when I show you some of the comparisons I'm making later and talk about the specification, other ideas about changes in civil rights will come up again for sure. Okay, so why would we think that this short-run increase, or this sort of contemporaneous increase in medical care use among poor kids, should actually even matter in the long run? First, I want to just point out we have a lot of just black box correlations between child health and adult health. So, for example, this is just one example of many using the PSID. So Jim Smith got the PSID and looked at contemporaneous health across different adult ages and plotted that separately for respondents who said they were in good health before age 16 or bad health. You can see that kids who are adults who are healthier kids are healthier, and that those two lines spread out over time. So if you thought this was those difference in these two lines was causal, then you would say moving kids from the gray to the black line in early childhood would make them even farther apart in health in adulthood. So that's one correlation of many that exist out there. We also have a lot of specific, really interesting historical work looking at specific conditions. So this one doesn't have a black box because I actually think a lot of this work has really good identification strategies and can do a really great job focusing in on one kind of condition and asking what it should do in later life and documenting that it does. So this is this work is either looking at the geographic pattern of the incidence of such and such disease, or what happened when a certain disease was eradicated, and tracking those effects much later in life. So this isn't really about the whole package of just medical care. This is about one particular disease, which would clearly be wrapped up in medical care to some extent. But this stuff is really nice, and again, suggests that something like Medicaid should have mattered later in life. We have stuff that I'm putting kind of a gray box on because it's other related policies from this time that that have nice identification, but are not so focused in on just one channel. Sometimes they are, but not always. So we have nice stuff about the rollout of food stamps throughout the 60s and 70s. Some really great stuff about the later life impacts of hospital desegregation. And then, of course, there's this literature on Medicaid in the 80s that also suggests that Medicaid itself matters later. And then finally, well, not finally, but I also want to point out that I think the 60s should really matter later in life for another specific reason, which is that kids in the 60s were at a particularly low starting point in terms of childhood health, and were therefore maybe at a pretty productive state in terms of whether medical care could really matter for them. So there's a lot of stuff. It's not hard to document contemporaneous differences in health between poor and less poor kids in the 60s. But what I want to point out is the results of a 1964 study on the health of Army inductees that documented huge rejection rates for medical reasons among prime age men showing up to serve in the military. And then the military report notes that 75% of all persons rejected for failure to meet the medical and physical standards would probably benefit from treatment. And other parts of the report, they note that this stuff is correlated with contemporaneous SES for these young men. So if you thought that these men were a reasonable guess about where poor children were heading in the future, then they were headed for relatively physically limited adulthood. And so that would suggest that some kind of intervention early should matter for the incidence of this kind of thing later. There's also a huge policy change, so we'll go back to this figure and point out that the stuff that people have looked at before, actually the growth in the number of kids on public insurance in the 80s and 90s was probably larger than it was in the 60s, but that didn't correspond to nearly as large a reduction in uninsurance. So actually the 60s were this time when changes in public insurance seemed to go hand in hand with the largest reductions in uninsurance for any of this modern era of public health insurance. And so this suggests that it's a large policy change that should matter. And then finally, some of my earlier work on this topic finds pretty substantial short-run effects of Medicaid on infant and child mortality. So we also know that using the same kind of research design that I'll show you in a second, this thing actually did matter contemporaneously for child health. Okay, so what we're going to do, so we're seeking to connect policy variation in the 60s to adult outcomes. And one big challenge is just measuring what policy variation really means in this context. If we're looking at, my earlier paper looking at like contemporaneous outcomes, it's not hard to get information on AFDC, which I described a little while ago, and say, in this year, in this state, this is the AFDC rate. In this year, it's this and this and this and this, and go year by year. But for cohorts, it's not quite so easy. So I'll first tell you a little bit about how I do that AFDC measurement, because this turns out to be really important for how the paper works. So the first ingredient is just state by year counts of AFDC recipients. So you can go to HHS and just get Excel files that say this is the number of kids on AFDC in Florida in February 1967, et cetera, et cetera. And it looks like this. So you can just, this is the kind of table that Social Security Administration and Health Education and Welfare would print. It's actually possible that when I got this, I may have interlibrary loan requested it from the SSA library here a long time ago when I was in grad school. So this might even be coming home on this slide. The second part is, so one issue with that is that it's just a total count of children. And for some reasons I'll tell you, well, the analysis I do is all stratified by race. And so one really important thing is to take that count of kids and try to figure out how many were white kids and how many were non-white kids. And I do that using some archival information on the characteristics of AFDC recipients. And so that stuff looks kind of like this. This is like the beginning page of a AFDC study where caseworkers were asked about all this information about the cases that they handled. And so this lets me say, well, according to these surveys in Mississippi in 1969, this share of AFDC families had a non-white head or a white head or something like that. And so that lets me break up the counts of children into like white and non-white kids. And then you can get population by race back in this time from a couple of different sources. And so together that lets me calculate this sort of new measure that I get from combining all these data sources to say this is the AFDC, the share of kids on AFDC of race R in state S in year T. And that's just the total recipient count times this race share I calculate from there divided by a population. So that's important. That turns out to really matter. And when I have that in hand, I can generate a measure of Medicaid eligibility that resembles the categorical eligibility requirement we talked about a couple slides ago. Basically, if you want to know what share of kids in your state are eligible for Medicaid in 1 year, well, it's basically two things. It's just a dummy for did your state have Medicaid at all? So that's a sharp change. Medicaid goes into place, and suddenly a bunch of kids are eligible for public insurance. And because of the categorical eligibility requirement, the statutory link between AFDC and Medicaid, that jump is way bigger in states that have a lot of kids on AFDC than it is in other states. So to visualize that, this is a plot basically of that exact expression. Basically there's no Medicaid eligibility before Medicaid. That's a bit of an approximation that I'll talk about in a second, but essentially there's not much. And then when Medicaid goes into place, every state jumps. Some states jump to the top of the cloud, and some states jump to the bottom of the cloud. So this is the way that you go. This is a pretty straightforward way to go back and use historical information to say how many kids were eligible for Medicaid in each state in each year, each calendar year. The problem when we're looking at later outcomes is that some kids were born here and spent most of their life to the right of the red line. Some kids were born way over here and only spent a little bit of their life to the right of the red line. So for example, if you have some group of kids born 14 years before Medicaid, they might jump up here and be 14, 15, 16, 17, 18, and then age out. And some people at the top. But if you go back to the cohort born 10 years before, they're going to be exposed to a high or a low AFDC state for many more years. And so that's one thing that I need to account for when I'm looking at adult cohorts, is to say, not just were you born, it's a lot harder to define before and after, because kids are spending different shares of their life exposed to any Medicaid. And so that's the challenge that I have to overcome here. Complicating that challenge is that it's not like every kid born in New Hampshire lives in New Hampshire. They move. Kids move all the time. So that's another thing to incorporate into this measure, is you don't really want to just be assuming that everybody born in one state is exposed to that state's Medicaid policy forever. We know that's not true. Do you have a question?
What's the world of state-by-state variability in Medicaid look like in the 60s? Is it far less? Was Medicaid a lot more uniform back then?
Oh, that's a good question. Well, the central required benefits, basic types of care would certainly not have varied. Most states also covered drugs, but these are, one reason why it wouldn't have varied as much is because these were all mandatory populations, and they were not able to be charged copays or premiums or anything like that. And so there are things that vary across different groups of Medicaid recipients today that were not legally allowed to vary for this type of population that I'm talking about. So it's a good question, and I guess what I'm saying is, in some ways, yeah, state Medicaid programs varied on things other than eligibility, but in another way, the groups I'm focusing on were not able to vary across states very much because they were required and not subject to other stuff that people might want to do with a Medicaid program. Okay. Yeah, I'll show you some evidence on my AFDC measure and how it relates to other characteristics of states that everybody should be concerned about. Like, am I just comparing poor to rich states? Am I comparing generous to not generous states? Turns out the answer to those questions is no, but I'll show you that that's true in a second. Mm-hmm.
And is payment generally pretty uniform? I mean, that's the one thing to think about now.
Certainly states, yeah, no, I mean, states set different fees for stuff at this time, and it's really hard to get fee information now, and it's certainly hard to get it back then. No, it'd be nice to get better ways to back out Medicaid fees this time, but yes, unfortunately that's an aspect of cross-state Medicaid policy in the 60s that I have to punt on a little. Yeah, I don't know. So there could be, yeah. I guess unfortunately the best answer is maybe, but I can't measure it unfortunately. So. Yeah, it makes you, yeah, participation in Medicaid, conditional on being an AFDC recipient? Oh, yeah, 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 yep. Yeah. Yeah, no, that's a good point. No, physicians were making a lot of noise about this in the 60s and how it was socialized medicine and it was getting in the way of the doctor-patient relationship and the fees were terrible. So, yeah, some kind of measure of physician participation would have been great. But I don't know much about that. It's hard to measure at this time. Mm-hmm. Yeah. Yeah, that would be good. Mm.
There's a point in time where the HHS rules that states can set reimbursement however they want, and then a lot of physicians drop out because states lower the rates.
Yeah.
That might be another kind of interesting cutting measure.
Yeah, that'd be good to know about. Okay, well, so today I'm focusing on this AFDC-based measure of eligibility. And this is good stuff to keep in mind because it could be, the effects I show you could be driven by underlying differences I can't measure in other aspects of state Medicaid programs, but the one I can show you is this eligibility measure, which does vary a lot across states. And so just to briefly tell you how the migration thing gets built in. So, we know that this categorical eligibility requirement means that state AFDC rates after Medicaid starts are this really close proxy for how many kids are eligible. So that's easy, I can measure that. The way that I go about dealing with this migration is just to look back in the census. The census asks respondents, where do you live and where did you live 5 years ago and where were you born? So luckily they ask that every decennial census asks those questions. So I can say for 1970, 1980, 1990, 2000, all these years, I can say where do whites born in New York in 1960, where did they live at 5-year intervals? Well, 100% of them lived in New York in 1960. 10% had moved somewhere else by the time they were 5. Slightly more had moved away by the time they were 10, et cetera, and I can track the share of them until you get to 2000, which is a little beyond what I need, but 40 years later, just over half of them still live in New York. Well, where did they go? 4% of them moved to New Jersey, that seems clear. A bunch of them moved to California, because it's a big state, even though it's far away. Some others of them moved to Connecticut. So this kind of thing allows me to say, for every cohort, every group of people of a given race, born in a given state, born in a given year, I can track where those kids were living for all these years going forward. And that really helps because if I know on average where this cohort was living, I know on average which kind of AFDC environment they were exposed to in a given year. And so this is the way that I'm able to deal with this migration, is to kind of build it in to my preferred measure of childhood exposure. So I think these maps are cool. We don't need to spend a lot of time on them. This is where kids from New York were living in 1970. See, New York is pretty dark. California is pretty dark. Here we go to Michigan. It's obviously more centered in the upper Midwest. And here we go to California. It's obviously more centered there. So you can, these migration patterns make a lot of sense. And I think they're a good way to incorporate this feature into my measure. But this is what I come up with. So the components of my preferred measure of cumulative childhood exposure to Medicaid is this sum where I say, okay, well, what I'm going to do is add up the categorical eligibility in states where you might be living. So again, that's does the state where you're living have Medicaid, and what's its AFDC rate? And those things get weighted together by the state of residence distribution that I showed you before. So all this is saying is, for the whites born in New York in 1960, we say, well, they could live in any of the 50 states. Each of those 50 states has an AFDC rate in some given year, and we're just going to weight them together by the share of New York kids that we know were living in this state, in this state, in this state, in this state. So this is what you get here. You get this measure of across different cohorts born in different times relative to Medicaid. You can say, what is the cumulative expected number of years that they would have been eligible for the program. So cohorts born very far before, so 23 years before, they were never adults in the Medicaid period. They have no eligibility. Cohorts born 19 years before, like just made it maybe for 1 year, and cohorts born increasingly close have this phasing in of Medicaid eligibility until cohorts born fully after. So time zero is when your birth state started Medicaid. And comparing this cohort to 1 more year, 1 more year, 1 more year, they're not spending increasing years of their childhood under Medicaid. Their whole childhood is under Medicaid. So that's why this relationship slopes up and then kind of tapers off. And what I want to point out is that later in the paper, I'll be talking about effects per year of childhood eligibility, but I want to clarify that this is years on the cohort level. So it's basically the expected number of years for a cohort is kind of the probability that anybody in your cohort gets Medicaid times the number of years that the Medicaid getters were on it or were eligible for it. So that could be a small group, like 1/18 of your cohort is eligible for all 18 years of childhood, but it could equally, like 1 more year of eligibility could just as easily come from half that many people being on for half their child, or twice that many people being on for half their childhood, or it could be, half of people in your cohort had some Medicaid and they were eligible for 2 years each. So I just want to emphasize, when I say a year of childhood eligibility, you shouldn't really be thinking of taking one child and making them eligible for 1 more year. You should be thinking of taking a group of people and increasing average eligibility by 1 year, which maybe comes from increasing the sort of tenure on the program for a small group, but it could come from expanding access to a larger subset of that group of people. Okay, so that was an important detour about how to actually measure this program historically and how to cast Medicaid policy in the 60s into a sort of childhood concept of cumulative eligibility through AFDC. But there's a number of reasons why we wouldn't want to just sort of run from there and regress adult outcomes on that measure. So, for example, AFDC policy changed in very important ways after the 60s, and it could be the case that some part of the measure I just showed you is driven by reforms like happened in 1981. Those reforms may independently really matter for child outcomes, and I don't want to mix that up with what I'm calling Medicaid eligibility. Other changes in demand for low-income labor throughout the 80s and 90s, when AFDC tried to become more connected to like imposing different kind of work requirements and more connected to labor markets, that could also matter for kids and really, really drive what I'm actually observing in AFDC rates. Changes in demographics matter, so other changes in single female-headed households would be correlated with AFDC. We know that happened in the 70s and 80s. And then finally, that migration measure that I just showed you, that itself could be correlated with all sorts of other outcomes. It could be that like healthier cohorts that were going to be healthier anyway moved more and moved to different types of states. So there's all these reasons why we might not want to take that thing I just showed you and just put it on the right-hand side of a regression and see how outcomes relate to it. So instead what I'm going to do is take one particular measure of AFDC, which is the share of kids on AFDC in your birth state in the year that your state began Medicaid. So I just want to emphasize this AFDC Star, which is we're going to be talking about, is just a direct measure of how high was the jump when your state in eligibility when your state began Medicaid. This is just the first dot in that cloud. It's right there. So this thing gets measured by race, and this cloud is not by race. But basically, I'm saying what we're going to do is take this value for states and just use that all the time. So this is really helpful because it means that I can compare states by this one measure in any year. So you can see like New Hampshire is low in this measure, but then it kind of goes, it's not the lowest state anymore up here. So if I used, it would be really hard to make this comparison year by year because the ranking would kind of change. Here I'm just going to say, no, New Hampshire is the bottom here, it's always the bottom. And then I can compare this dot and say New Hampshire is the bottom here too. So this is basically the cross-sectional part of a difference in difference design where everything I do in the rest of the paper is going to essentially boil down to comparisons of outcomes for different cohorts who were born at different times before and after Medicaid. So that's like the people born 20 years before who were adults, the people born in years where they were exposed as teenagers, the people born in such years that they were exposed as young kids. So I'm going to compare changes across cohorts born in different years, but in states with different values of this initial measure. So some people accumulated eligibility at a much faster rate than others. And so that's the kind of, fundamentally this is what's going to be compared when I show you these outcomes. And so to believe this, to believe everything I'm saying, it's going to be really, some of this has come up, but it's going to be really important to know why is a state at the top or the bottom of that cloud? Because it could really easily be the case that states with high AFDC rates are fundamentally different than states with low AFDC rates. And we could come up with all sorts of other stories for why the outcomes for their kids would diverge over time. And so what I'm going to argue basically is that at this time in particular, states found themselves with high or low AFDC rates for lots of kind of long-run historical institutional reasons. It's not something, so differences across states in AFDC was not something that just emerged contemporaneously in the 60s. In fact, those differences were there in the 50s and in the 40s, and some other really interesting work in economic history suggests that states, the way states ran their AFDC programs in the 30s, 40s, is even related to the way they ran mothers' pension programs that predated AFDC. So lots of the differences that we see in AFDC in the mid-20th century actually had their origin in stuff like sort of the pre-existing industrial structure across states. So agricultural states had this big incentive to keep down payments and provide low benefits, and so that leads states with lots of agriculture to have low AFDC benefits and low participation. There was tons of overt racial discrimination in the AFDC program that was obviously not written into the law, but really mattered, particularly for differences in participation for white and non-white families. This was huge, and as Harold mentioned, like largely litigated in the 60s and 70s. This paper by Carolyn Mayling is the one that establishes a link between mothers' pensions and ADC programs, and talks about how the way that states made this choice, in the teens, really affects the structure of how these programs worked after the Social Security Act. And then there's some interesting stuff about the way that different state constitutional structures limited states' abilities to expand spending on social welfare programs. So this is something that would have been in place long before the 60s, but nevertheless really mattered for how some states structured their AFDC programs. And so basically, when I compare cohorts in high or low AFDC states, these things are historically stable, so it's not just something that came from the 60s. It was there long before Medicaid. And it was largely arbitrary with respect to children's circumstances. Many of these factors, even if they mattered for like a little bit of cross-sectional differences, they really weren't mapping strongly to how the circumstances for kids changed in the mid-20th century. So I'll show you that specifically. So there's a lot of ways to put data together to test those claims and to argue that, in fact, like when I compare states by AFDC, that I'm not confounding that with other stuff. So for example, this figure takes a bunch of information from vital stats data. So infant mortality, birth weight, sex ratio at birth, many other share of births in the hospital, and I kind of combine them together in an index, and I can say, well, are these circumstances of health at birth changing for different cohorts in higher or lower AFDC states in the lead up to Medicaid? So each of these dots is like a regression coefficient. That's the interaction of this particular cohort with this AFDC Star measure. And so if we were seeing cohorts in high AFDC states getting systematically healthier over time, then this would be a really strongly positively sloping line, and you'd say higher AFDC states are like having better and better and better birth outcomes throughout the 50s and 60s, and that would really confound some comparison before and after Medicaid. But in fact, that doesn't seem to be the case, neither for whites nor non-white infants. Each point is pretty noisy. If I try to put a line through it, that line is not statistically significant. And so this suggests that in terms of this one particular measure, health at birth, AFDC doesn't really predict differences in changes in health at birth over this whole kind of 15-year period prior to Medicaid. I can do the same thing using census data on other kind of SES measures. So this figure is structured the same way. You would be, these are coded to be, they're coded to be, let's say, I think bad. So we want, if the high FDC states were getting better, these would be falling. But again, doing things like, measuring different points in the child income distribution, child poverty rates, education of parents. for 50, 60, and 70, these things are not changing differentially. So again, we're not seeing cohorts of children who are exposed to systematically better or worse sort of circumstances in childhood across this measure. I like showing this because it was a fun data collection effort, but this AFDC measure also is not correlated with other kind of public health efforts that would have predated Medicaid. So someone brought this up and I thought it was a really interesting idea. Since I'll tell you about disability in a few minutes, people say, well, aren't you worried? What about the dissemination of the polio vaccine? That's affecting cohorts born in the mid-50s. We has a clear connection to disability. So I had an RA go to the March of Dimes archives in White Plains, New York, and get a bunch of information on how the March of Dimes helped to disseminate the Salk polio vaccine in the mid-50s. And so I can get different measures of that and scatter it against this AFDC measure. So the top is the total number of polio vaccines shipped to different states by 1957, which was a few years after it was first approved. The next is the infantile paralysis case rate in 1945. So this is not polio deaths, it's just like reported polio cases among infants. This is the change in the infantile paralysis case rate, 40 to 50. So this is sort of a trend in polio prior to the vaccine's development. And then this is the change in the polio, sort of adult, any polio rate, pre and post vaccine. So all these measures, you would think these represent both direct efforts to combat polio, and I think of them also kind of as proxies for other public health stuff that states were doing. And we would be concerned if these things were systematically related to the AFDC rate in different states, because that would say, oh, maybe these states just do more public health stuff. And it seems that they don't. So this isn't correlated with my measure of sort of white child AFDC rates, and it's not correlated with my measure of non-white child AFDC rates either. So again, these states don't seem to be doing different public health stuff, which is good. It turns out that one good thing is that AFDC is strongly correlated with actual Medicaid use. So this is a picture from my previous work where I collected information on participation by state in both Medicaid and in the pre-Medicaid public insurance program. So maybe you'd be concerned that some states just already had generous programs and Medicaid just replaced them and nothing changed. And that doesn't seem to be true. So here I'm taking the share of kids getting some kind of medical payment. You can see it's small before Medicaid goes into place. And asking, like, how does that share change when Medicaid goes in high versus low AFDC states when Medicaid is put in place? And you see that high AFDC states have a huge increase in the share of kids who are actually getting some kind of public medical program. So not only is this thing not correlated with a bunch of stuff that you'd be worried about, it's very correlated with the actual thing that it's supposed to measure, which is, do kids actually get Medicaid? And then just to reiterate, my earlier work suggests that not only is it correlated with Medicaid use, but also with contemporaneous child health. Okay. So I won't talk about this too much, but this is just the regression specification. I want to point out that I've been talking a lot about comparing cohorts before and after Medicaid, and so the main results I show you will just be pictures where I'm going to plot coefficients that are interactions between the AFDC measure that we've been talking about and different dummies for cohorts born in the years leading up to a Medicaid program. So this first sort of sum is basically a direct measure of pre-trends. These are dummies for cohorts that are born before Medicaid, and so never should have been exposed to it as children. And so the really important thing there is going to be to look for the sign and the magnitude and significance, and maybe estimate a trend. And these are cohorts where we do not want a relationship between adult outcomes and AFDC rates for cohorts who never actually had any Medicaid. So this thing is a direct falsification test, and we'll plot these things and look at and hope that they are small and flat. Cohorts, the coefficients of interest for cohorts born in the years leading up to Medicaid contain a lot of information about what Medicaid might have done, because I don't have to impose anything about whether Medicaid matters at age 18 or 16 or 14 or 10. Actually, the data can tell me that directly. All I need to do is say, how do adult outcomes change differentially in high versus low AFDC states for cohorts exposed at this age or this age or this age? And so these coefficients are really going to tell us about when coverage starts to matter and how much. And so I just want to note that cohorts born closer to Medicaid actually vary on two things. They get a higher dose of Medicaid in that that's the cloud was sloping up. and they're exposed at a younger age by definition. So there's actually, unfortunately, no way to really separate those two features in this design, but both things are going to contribute to the estimates I show you as we kind of go look across cohorts and see when do the effects really start to phase in. One thing that's important to note is that we actually have another test of this design, which is that eligibility was phasing in as cohorts were born up to Medicaid's beginning, but actually that relationship flattened out after cohorts were fully exposed. And so we can look for a similar kind of kink in this relationship when we have adult outcomes on the left-hand side, because if adult outcomes are getting better and better and better in higher AFDC states for kind of the middle cohorts, they shouldn't keep on getting better and better for the cohorts born fully after, because they have differences, but they're not growing with successive cohorts. So it's another thing we can test in this kind of design, which is very helpful. I'm not going to spend time talking about the other covariates in this model. They might come up with some questions, but I'll just let them come up as people have concerns. Okay, and then finally, before we actually show results, so this has been I spent a lot of time like arguing that the thing I'm going to show you is believable, and now we're like more on the cusp. So the outcomes that I'll show you in this context are, first of all, a measure of cumulative mortality. So I go to the vital stats data, and for 1979 to 2004, public vital stats data contain a variable for the state of birth of the decedent. And so I can get a count of deaths for kids born, whites born in 1960 or something. How many of those kids died for this 20-year span? And then I just divide that by the population by state of birth in year of birth in 1980. So this is a sort of summary measure of later life mortality representing sort of 20 years of a mortality experience. Then I can go to the census and ACS and calculate a bunch of health and labor market outcomes, because the census and ACS always ask where you're born. And so again, I can calculate these measures at the state and cohort level. So I'll show you results for disability. So there's a range of self-reported disabilities in the census and ACS, a number of measures for labor supply, and then participation in different public programs. Then I'll show you some stuff about income by source to try to figure out if Medicaid is kind of a long-run anti-poverty policy or not. And then I just want to note, everything here is I just collapsed this all down to averages by the birth state and birth cohort and race. So for each race, there's basically, I keep about 41 years and 49 states. And so, this is based on a lot of underlying individuals, but the regressions themselves only ever have about 2,000 observations in them. Okay, very briefly, we're going to ask the simple question, which we should kind of have a sense of, which is, does that initial AFDC measure actually predict the migration adjusted one that we talked about? It might not. I mean, if you thought that the migration really, really was strong and kids from low AFDC states moved to high ones or vice versa, you might say, well, maybe the conditions at the start of the program don't actually predict cumulative exposure to it. And they do. So there's no relationship between coverage really for cohorts that never had any coverage. The effect of sort of spending one more year in a state with a little bit higher AFDC rate is to have your coverage phase in for these cohorts and then taper off for cohorts born fully after. So this is just verifying a thing that we think should be true, but we needed to check that when I show you results for outcomes, in fact, these are cohorts that really did have more eligibility for Medicaid. Okay, so do initial AFDC rates predict changes in adult health? We're going to roll out the mortality estimates piece by piece. So this is the falsification test for adult mortality. These are cohorts that these people were 30 years old when Medicaid started. They clearly have no childhood coverage. These people were 20 years old, 19, 20 years old. They have no coverage either. And in fact, this relationship is small and flat. It's actually flat too for cohorts that were teenagers when they first got coverage. So this is already telling us something about treatment effects. Medicaid doesn't seem to matter in the long run when you only get it as a teenager, at least by this measure. But for cohorts that got Medicaid at younger and younger and younger ages, starting at about age 10, adult mortality rates really start to fall for higher AFDC states relative to lower AFDC birth states. And then afterwards, there's a little bit of a tapering off. And so this is kind of exactly the pattern of results that we would expected, given the way we know cumulative eligibility was phasing in. So this is the mortality result for white adults. And this is the very similar looking result for non-white adults. So this is suggesting that on kind of this initial check for a pretty extreme health outcome, cumulative adult mortality, a given amount of childhood eligibility seems to do something quite similar for white and non-white adults. Actually, my preferred measure is this one, which I can explain if you want, but one kind of issue with this mortality measure is that the incidence of the AIDS epidemic being very, very strongly correlated with these cohorts. So cohorts born in the 50s and 60s suffered the brunt of the AIDS epidemic in the 80s and 90s. And it was strongest for non-white men in places like New York and New Jersey. That happens to be correlated with, those happen to be high Medicaid states. And so one way to deal with that is to just use some demographic methods to remove the sort of force of AIDS mortality from these estimates and look at similar pictures that aren't in principle affected by AIDS mortality. And actually they're very similar, but if you notice, just a lot less noisy. Yeah, Harold.
How about
Homicide, homicide is in here, but then I can look at it separately, and particularly for whites, it's a flat line. There's actually
Is the crack epidemic?
yeah, I did. I had some kind of first cut pictures using the like Roland Fryer crack index, and they weren't that strongly correlated, but there might be better ways to bring it in. That's a good idea. Okay, so this table shows you some numbers that are slightly easier to understand, but I'm not going to argue to your face that this should be like obvious to interpret these numbers right away. These are the estimates that where I just calculate like a predicted dose of childhood Medicaid eligibility using my kind of initial measure and use it as an instrument. So this is saying like the effect of one additional childhood year on adult mortality in terms of log points. And so these are the IV estimates, but I want to go through, I'll tell you how big those things really are. If I use these estimates to say, well, okay, this is the effect on adult mortality, we can use other data to figure out how many kids from a given cohort had childhood exposure, how much did they have. You can get a sense of how much must mortality have fallen among the subset of a cohort who actually had childhood AFDC participation to rationalize these effects. And that's the number I think we care about. How much did Medicaid affect the mortality of the people that it actually treated? And so it suggests that for white kids in some other surveys who report, if you look at the PSID and you say, how long did white kids who received any AFDC receive it? On average, it's about 2 years over their whole childhood in different spurts. And so these estimates suggest that for kids like that, Medicaid exposure would have reduced their adult mortality by about 16%. And for non-white kids, they had more exposure, and so Medicaid would have reduced their adult mortality by about 30%, which is a large number. I mean, this is a big reduction in your mortality risk. But actually 30% is pretty consistent with what a lot of other contemporaneous studies find about health insurance on contemporaneous mortality rates. So for example, my short-run mortality stuff actually finds a very similar proportional reduction in the contemporaneous infant and child mortality rate for non-white kids. So this is basically just another number saying health insurance matters, and it matters to a similar degree, and it's reducing mortality in yet another context. So again, for whites, no effect on homicide or accidents. It's noisy, and unfortunately it's negative, but it's kind of noisy for non-whites. And actually these are spread across a lot of different causes. That historical work I talked about in the beginning that focuses on individual diseases is great because you know exactly what to look for. But Medicaid's a challenge because it just provided medical care, and it could have plausibly affected lots of stuff, and I find that it did. So there are effects for cancer, there are effects for cardiovascular mortality, there are effects, there are noisier effects for lots of different causes. So this is not just coming through one thing. And one thing that actually, where it does show up is in suicide. So suicide's not driving the overall result because underlying suicide mortality rates are low compared to other causes of death, but there is a pretty meaningful treatment effect on suicide, which given changes in other kind of chronic illnesses, given the effects I'll show you on disability a little later, I think that this is part of a story about just improving adult health overall, and there might be people whose underlying health puts them in this kind of chronic illness, chronic pain, suicide situation. So it wasn't what I expected when I first ran mortality regressions, but it's something that's pretty robust across specifications. Yeah?
So in the way we've estimated it here, you've estimated it here, it's like there's large changes in Medicaid
It could be, yeah. So this is maybe something Colleen was mentioning, or we were talking about earlier, where, yeah, you could imagine that, so the best analogy I have for this is a story that people tell, like some of the architects of Medicare tell, you know, about how, you know, the week before Medicare went into place, hospitals were crowded with like poor old folks, and they were, you know, they could be really terrible places to be. And then when Medicare went into place and people could go elsewhere, they did. And those hospitals were not nearly as crowded. And that made it easier for people not on Medicare to go to them and get some kind of care. So that could be, something like that could have happened with Medicaid. If the patterns of care, if the types of places that Medicaid kids were getting care changed, it could have mattered for other kids too. And then maybe you even have other things in mind. So I think that's a good point to mention, is that I'm doing these calculations as though the only people affected by this policy change were the kids who had Medicaid exposure. But some of the things you're mentioning suggest that these could be spread across broader groups than that.
And then I guess also I have the notion of like, your estimates are heavily weighted by like these big states, these states with big increases.
Oh, I see.
Is that correct? And so,
yeah.
then different things might be happening in those states.
That's true.
Where, like, I feel less embarrassed to be on Medicaid.
Yeah, no, that could be true. I guess the only thing, okay, so a couple of things I've mentioned. First of all, some of the balance tests that I showed before suggest that by other measures, those states aren't substantively different than other states. That doesn't mean that Medicaid itself doesn't change things like you're mentioning. Yeah, that's a good point. Oh, I know what I was going to say. These results also come through when I use like a binary measure of AFDC, so just splitting states at the median, saying high or low. And econometrically speaking, that does take a little bit of the weight off of the highest and the lowest AFDC places. And so the fact that results are also there for a different way to specify my AFDC variable suggests to me that while the highest states matter, these comparisons still generate this type of effect when I'm not comparing the highest to the lowest, and I'm comparing kind of like places that are closer to the middle. So I think your ideas are right, but it's not the case that these are critically dependent on like the highest AFDC versus lowest DC places.
So by construction, your treatment group that's getting Medicaid already has AFDC.
Uh-huh.
So in a sense, you can think of it as a sort of an interaction, even though the AFDC isn't changing, right?
Uh-huh.
Your treatment, getting Medicaid on top of having AFDC. Is that
Yes.
the way you might think about
That's a good idea.
these results, or how they might generalize, or is there some
Mm.
kind of sort of income effect possibly going on that the AFDC enables that just giving Medicaid is not?
That's a really good question. Yeah, I mean, certainly the policy implication of that interaction mattering would be that like changes to Medicaid to non-cash transfer families might be totally different than this. No, that'd be interesting. It'd be interesting to go see if you could figure out, well, let's see. So there's some other folks have done another long-run Medicaid paper using the PSID. Slightly different design, but they've also found long-run benefits of the program. But they've also gone back and cleaned up some surveys of consumer finance that were done starting, I think, in the late 40s that ask about medical debt. And I'm a little skeptical about how those questions are actually recorded year to year, but they have some findings that suggest that the incidence of medical-related debt fell as well. And so that would be one reason that'd be another angle on this, would be to say, yeah, maybe financial circumstances matter too. And I think people think that that's important in the 80s as well.
And that might be a reason why you might find some effects in causes of mortality that aren't necessarily related to healthcare. Right?
Yeah, that's a good point. I like that. Okay, so this was the first set of health results for mortality. So I can measure it in large samples. It's pretty extreme. It's a nice and unambiguous measure of health. Now I'll show you the same type of figure for ambulatory difficulty, which is the variable. It's the census self-reported disability variable that's most common, other than the self-reported work limitation, which I think other disability researchers have been skeptical about how people answer that question. So this is going to be the share of cohorts who say that they have a long-lasting condition that substantially limits their ability to walk, climb stairs, reach, lift, or carry. And so here are the results for whites. There's no reason that these effects for mortality and disability needed to both phase in right at exposure under age 10. These are totally different data sets, and I was a little amazed that that seemed to happen. And I should also note I'm picking age 10 from sort of like a empirical procedure where I fit a bunch of trend breaks and figure out which break point fits the best, and for this it's age 10. And so this is telling us a very similar story that cohorts first exposed to Medicaid at age 10 or younger really have an increasingly better health when exposed to more Medicaid, and we have this really sharp kink right here. So I just want to point out, like any other story for why these effects should be there, of which there are many, don't just need to say stuff changed for cohorts in the 60s. They also need to rationalize the fact that then things flatten out for cohorts born here and after. And so to me, this is a pattern that's very hard to pin on things other than Medicaid. So here's the disability effects for non-whites. Actually, they're not, their magnitude is not that different. It's just that the effects for non-whites really only phase in at a younger age. And they're a little noisier. So I've had to think about this a little, but yeah. Go ahead. I could, one problem is population denominators for certain things. For the mortality, for example, it's really hard. I peg all this stuff to 1980 because the way that people respond in terms of self-reported race on the census changes in really interesting ways when they're allowed to do more stuff. But the race reporting on death certificates is not nearly so nuanced because sometimes the funeral director fills out your death certificate, sometimes it's a medical examiner, it's a lot of stuff. So I'm pinning all these very coarse, and I guess I should have said, like, I realize these are extremely coarse race definitions, but it's all pinned, it's all like the lowest common denominator of what I can measure across data sets. But yeah, no, that would be an interesting question. I think maybe others, well, ideas about how to get at that would be very interesting. I don't have a better one.
Well, so we should probably let him
I'm,
to make sure that he gets all
yeah.
that stuff.
Okay. Okay, so this is the end of, these are the two, I mean, I'm not showing you results for the other self-reported disabilities, but I just want to end the health section before we move on to labor market stuff. That's the end of the talk. And just say, like, these effects represent a lot of lives saved that are worth a tremendous amount of money to individuals if you take even a conservative estimate of like value of statistical life from economics literature. And these, the reductions in physical limitations from this disability stuff it's a lot harder to value that, but I think we have really strong priors and some other specific evidence about just how valuable that should be to patients. And just to reiterate, these things are spread across a lot of different conditions and causes. So Medicaid seems to have had its health effects through a pretty broad set of physiological channels that I would love to pin those down in more detail, but it's hard. Okay, so now so we know that which cohorts were healthier in which ways. They're probably healthier in other ways, but the ones I can measure are mortality and disability. So now I want to show you outcomes for the other kind of labor market stuff in the census and ACS. So this is a picture that should look familiar from the last two, where the outcome in blue is any annual employment. So this is a share of cohorts who just report being employed at all during the year. And the share of cohorts who report getting some kind of disability-related transfer benefit. So that's SSI and SSDI. And again, this is these are the same cohorts in the same data set, but a totally different outcome that didn't need to change right at age 10. But it should be totally clear that the same cohorts who are healthier by both measures in this particular pattern of like effects phasing in and then flattening out work more and are much less likely to get some kind of disability-related transfer. So to me, these are like very proximate labor market outcomes to exactly the health stuff that we saw improve. So the story is cohorts with more coverage are healthier by two measures, and they have higher extensive marginal labor supply and get a lot less public transfers for programs specifically related to those kind of conditions. So we can kind of dig into that a little more, and I'll just show you some of these effects by subtype. So the picture, this maroon line was for any disability-related transfer. Actually, that goes down more than total public assistance does because some subset of people, and this is driven by women, are less likely to get a disability benefit, but more likely to get other benefits, which is basically TANF or just in some states maybe general assistance. And that makes sense because if you're eligible for both, you definitely want SSI or SSDI. But if you stop being disabled, it doesn't mean you're not eligible for another transfer program. So there's some kind of actual shift. It's not just a pure story of reducing transfers. For some subset of people, it's a shift from one type to another. And then there's also kind of intertemporal effects within the public insurance system. So by virtue of not getting SSDI, a lot of these cohorts are much less likely to get Medicare associated with their SSDI or Medicaid associated with SSI. And so public insurance falls a lot. But because we saw they're employed, it's not like a huge reduction in any insurance, although it is a little bit. It's mainly just a reduction in the share of people who are on some kind of public insurance program. These are the different kinds of employment outcomes, but you saw the one for any employment, so none of these are all that surprising. It's just worth noting, most but not all people are in some kind of full-time, full-year employment, but that's by no means the entire effect. Okay, so the last thing I'll show you from the census is my best attempt to figure out what this is doing to income. And so this is how I'm going to motivate it. You could imagine, so like we showed all these event study pictures for many different outcomes. You could imagine just taking the income variables and creating a bunch of different measures and saying, what's the probability that you earn greater than 0? That's the navy line with open circles. And of course, that looks just like the employment line, because earning positive amount is any annual employment. But you could just move that threshold up the income distribution and say, well, what's the probability that you earn $10,000 or more, $20,000 or more? Or $100,000. So what we see is that Medicaid is having sort of a decreasing effect on those outcomes. And by the time you get to saying, do you earn $100,000, childhood Medicaid has no effect on whether members of your cohort earn $100,000 or not. And so what I'm going to show you in the next picture is I wanted to show you these to tell you where this comes from. But what I'm going to plot for you is these effects these effect sizes that say what is the impact of one additional year of cohort level eligibility on the probability of earning different points throughout the whole distribution. So this is where they come from, but I'm going to plot the whole distribution for you here. The top line is just plotting the effect on the distribution of earnings. And since we know people worked more, it shouldn't be surprising that earnings go up. But what you can see is that the increase in earnings is very concentrated at low levels of earnings, which makes sense because this was a program that targeted poor kids in the 60s in the US with low intergenerational income mobility, so they're not high earning adults. We knew disability benefits fell, so transfers fall, but nobody gets transfers transfers aren't that high, so there's no effect at high levels of transfers. But what's really interesting about this picture is that total income's not all that different. So, I mean, people were way better off in terms of their health, but they're actually not significantly better off in terms of material well-being. And so this is suggesting that Medicaid's long-run effects are big, and they matter a lot in terms of physical well-being, but it's not really a long-run anti-poverty program. Another take on this is that the disability insurance system works pretty well. This is exactly what it's supposed to do. So when people aren't disabled anymore, they work a little bit, and this is how it's supposed to go. So there's a lot of other discussion out there about DI and how it works and what its issues are, and this suggests that, that it's actually doing its job. So the last thing I want to show you is how I use these numbers to figure out not what this does financially for individuals, which I just showed you isn't a ton, but what it does for the government. Because actually, those changes in the composition of income, more earnings and lower benefits, the government benefits from both of those things. So basically, this sums up to $21 billion in savings today because of the behavioral responses of these cohorts. So there's a little bit of increase in tax revenue. I mean, these are low earnings, so they're not taxed that heavily. But the federal tax revenue goes up by about $6 billion a year. A little bit of benefit from people not spending on Medicare, which I don't get it in the census, but I'm imputing it from some other spending information on Medicare, disabled Medicare beneficiaries. And then a big benefit to the government of not paying out DI benefits to these cohorts. So the government saves like $12 billion a year from that. And if I compare that to what I estimate from sort of my historical data collection on what it cost to cover these cohorts for their childhoods, it suggests that they cost about $132 billion. And you could divide one by the other, but the one really hard problem with that is that the costs and the benefits are separated by 50 years. So unfortunately, in this case, discounting really, really, really matters. So if you do the typical econ thing and you say discount rates are 3%, then we earned a huge return on this $132 billion every year. And in fact, we've totally paid for the program. That's not my preferred strategy here because lots of the spending took place in like the late 70s, early 80s when interest rates were really high. And in fact, Office of Management and the Budget, when they do these cost-benefit projections, they're mandated to use Treasury rates to discount costs and benefits. And when you do that, you get a much lower return. But still, it's a pretty significant meaningful return per year, and it suggests that if you just add up the savings in the years of this study, which is very conservative because they could have been accumulating before, they're almost certainly accumulating after, it suggests that we've earned back 28% of what we spent on the program originally. And this is just from the government's point of view, not building in the value of any of those health benefits. So that's the end. Thanks very much.